Okay, part two. So we're gonna start getting into a little bit of my specific research as it relates to the field, and it's just because we're in wound healing. I do a lot of wound healing. Okay, so I'm not gonna be one of those faculty that in the cancer lecture I start sneaking in wound healing slides. Because it's my stuff. You guys have all been there. But I do wound healing, so this is kind of what I'm known for. And I love this topic. I love this passion. I've been doing it for almost 2 decades. And so a little bit of what I want to share with you is kind of where the field has been, how we're looking at things of replacing cells and tissues and replacing the matrix. And I want to start off this portion of the lecture talking about stem cells and how they can be used for different types of wound healing applications. And what you see here is you see cells that are found in the bone marrow. So a bone marrow derived stem cell on the left. And these have been all pseudocolored, right? And they make for better poster pictures, and they make for better presentations. They don't really, the bone's not really purple and the cell's not really yellow, okay? But it sure looks cool. And then you see some circulating cells that are found on the right. So these would be blood circulating stem cells. What is a stem cell? I'm going to touch on this on Friday in my lecture with the Festival of Science. There'll be different cool pictures, but we're still going to be talking about stem cells. What are stem cells?
They're basically the precursor cells for maybe branch off to make them mechanics.
They're the precursor cell. They're the cell that can usually differentiate. It's a fancy word that means turn into or change into another cell type. And we really have kind of 2 main categories, and this slide showing 3, but I'll explain how it's really 2. We've got what we call embryonic stem cells, and then we have what are called adult derived. Okay, so those are the real 2 types of stem cells. How many of you are familiar with the embryonic stem cell topic? Well, okay, it's hard to miss it, right? So in your phase of life, it's not as rampantly being discussed as it was when I was in your chair. Okay? Embryonic stem cells used to be the craze. They used to be kind of where everyone put all the future of medicine within embryonic stem cells. But the problem is that there are some major limitations that are associated with embryonic source tissue. Number one is you have to have an embryo, okay? And it's not like you can go into Walgreens and say, I'll take 3 embryo and a bottle of Listerine and some Crest toothpaste. It's not easy to get embryos. Okay, and if you have access to embryos, usually like in an in vitro fertilization clinic, you have this ethical, moral question of, and we're not going to go too far down this pathway, but is that a life? What do I believe? And if I use it to save somebody else's life, did I just sacrifice one life for another? Okay? So you can see how that could take more than 2 hours, and we don't even have 2 hours left in the lecture. So we're not going to go down that rabbit hole too far, but you can see why mainstream embryonic stem cell treatments haven't been super popular. You with me? Well, there's also a scientific reason. So there are ethical concerns, there's no question. The nuclear transfer is just another form of an embryonic stem cell that you can get from in vitro fertilization, where you actually take the nucleus from the embryonic stem cell and you transfer it into another cell type, essentially making it embryonic-like. But you still have to get the nucleus from an embryonic stem cell. Okay? So for all intents and purposes, these are both embryonic tissue. The destruction of a human blastocyst it requires donation of either the egg or the blastocyst, and it leaves a lot of ethical questions. But there are also some limitations scientifically. It's not just I don't want you to walk away from this class going, oh, well, Keller said we don't use embryonic stem cells anymore because of ethical concerns. Well, that's part of the story. The other part of the story is we have tried as a field. We have absolutely tried, and we haven't been very successful. The number of successes on embryonic stem cell research has been very limited. And if you read the literature, what you're going to see very quickly is there's a lot more times where it goes wrong than it goes right. There's a lot more unmanaged teratoma or tumor formation that results from the blastocyst being transferred than, oh wow, look, we just regrew a new organ. We're so amazing, right? It's usually, what the heck is that? It's got teeth and nails and hair, and I don't see anything that looks like an organ, right? It looks like messed up, new human. So there's a lot of scientific reasons that the field has moved away because we don't really have enough tools yet to control the power within embryonic stem cell. Now you go over to the category of adult stem cells, okay? They're not controversial really at all. In fact, there are neonatal sources. That's sources of stem cells that come from a very young tissue, but because it's not an embryo, the line between embryonic and adult is after birth. So once the organism is born, if the organism is fine and living and baby is celebrating with mom, anywhere else in that environment that's leftover tissue that's not being used anymore, if you could harvest stem cells from it, they would be considered neonatal, but still in the category of adult. You got the placenta, which is usually thrown away. Okay? You have the umbilical cord and the blood that's within it. It's usually clipped off, cut, discarded. So there's a lot of research that's focused on placental research as well as umbilical cord research. Not controversial. There's plenty of that tissue available. Okay? And instead of ending up in a landfill, why wouldn't we actually try to pull cells out of it or cellular products and do something helpful? Make sense? Okay. So that's where this is going. I'll talk a lot more about this on Friday. In fact, one of my companies does exactly this over on the adult side. Okay? Another slide that kind of describes different iterations of where you can take these cells and how you can utilize them. So here you can see all of the little details. We've got embryonic stem cells. This is by nuclear transfer, right? So, it involves cloning a cell. It involves fertilization that takes place. And you either got a fertilized embryo that grows out, or you've got a nucleus that came from the donor cell inserted into a recipient, and now you have a cloned embryo for the nuclear transfer. So the two different types of embryonic stem cells up top. iPS cells are normal cells that are now programmed by transfecting them with stem-associated genes to make them behave more like embryonic stem cells. Okay? So we went through a whole phase of induced pluripotent stem cells to make them behave like embryonic stem cells. And then, of course, the adult stem cells that I talked about, the sources, here you can see placenta, amniotic fluid, cord blood, umbilical cord blood, and then bone marrow. And there's another one that you can add to the list that we've done a lot of research, and I'll show you some of that on, is fat. You actually have a tremendous number of stem cells in your fat. Okay, so at Thanksgiving, when Dad's like, oh man, I need to lose some weight, I said, no, Dad, you're fine. You're just storing up stem cells for the future, right? That's exactly where a lot of those stem cells sit in you and I. In our extra fat, we have a lot of stem cells, okay? And so we have this whole field that takes lipoaspirate from a liposuction procedure, and it harnesses the stem cells and is using it therapeutically in that same patient, right? And they're like, awesome. So you make me look better, and then you save my life. I like it, okay? So, these adult-derived stem cells, you've got all sorts of different sources, and I've over the years playing around with these different sources. We have fat sources, bone, muscle, cartilage, that these cells can become. So here's the patient is donating the fat tissue that's adipose-derived. You do an aspiration and a wash, you centrifuge, you harvest the stromal vascular fraction, okay, from that centrifugation. You grow that out, and in the stromal vascular fraction are a population of adult-derived stem cells that have all these different types of cells they can become. So let's characterize the different terminologies. And on one of the early slides is where I should have done this, but darn it, this one I don't think is working. Blue. Well, we've got embryonic stem cells. These are considered totipotent. Totipotent meaning they can become pretty much anything. And then adult is where we call pluripotent. Many potentials, pluri. Total potential, many potentials, okay? But even within the many potential of adult derived, it seems like we have enough power in the adult derived stem cell that we can actually turn it into all sorts of different types of replacement cells, okay? So this particular project, we were actually spinning scaffolds using the process known as electro spinning. This is trying to create a matrix. Now, why were we chasing after the matrix? You guys tell me, why were we spending so much energy trying to make a biomimetic matrix, a matrix that resembled the original matrix, from what we've told you today? To reduce scarring, to facilitate cellular ingrowth. The cells say, oh, this is sweet, this is going to be so easy. I'm going to move into this matrix, and I'm just going to do what I do. If you make a matrix that doesn't resemble the native tissue, you promote scarring. The cells have to spend most of their energy making a matrix. So electrospinning works like this. It's very straightforward. There's a high voltage power supply. It's connected to a needle that has a positive charge. The negative charge target is down here some distance away. You deliver through a syringe pump to this needle that's positively charged a proteinaceous solution. And when it hits this electric field, it goes from a liquid to a solid. It polymerizes. And as it falls on the target, it turns into a biomaterial or a scaffold. This is what the setup looks like. Let's see if this video works. Oh yeah, there it goes. So you can kind of see and appreciate in this video that this looks a lot like spinning spider webs. So you can kind of appreciate the stream of protein fibers that are coming out. This is what it looks like. Okay, so we can set this electro spinner for all intents and purposes to different settings to make different types of extracellular matrices. Okay? Why do we do that? Well, all of the white fibers that you see are the things that the cells would hang on to. That's the jungle gym. Cells are going to move into the black open spaces. They're going to take residence, and they're going to hang on to those. They're going to hang on to those fibers, and they're going to start to make some matrix proteins, but not as much as they would have if you didn't supply them with all this. But more importantly, they're going to start making their growth factors and cytokines that they normally make to cause other cells to move into the area. So you can see the two different types of scaffolds. The right image is at a slower flow rate, and it has a more open architecture. And then the left image is a faster flow rate of the polymer, and so it actually makes it more dense. So we can dial in, and what we call it is called biomimetic matching. So we'll take a piece of donor tissue, right? We take an image of it, we analyze it, and say, okay, it's about this porosity, the fibers are about this size, and the protein matrix is the following. And then we make a formula with the right protein matrix, we set the setting to the right fiber diameter and the right porosity, and we spit out a Frankenstein piece of skin, right? So we are electrospinning skin. In this particular study, you can kind of see this is scanning electron micrograph like the previous slides. This is the bare matrix back here. And you can ignore this ASU logo. Our scanning electron micrograph was down, so we had to drive to Tempe to borrow theirs. They were very kind, but I can't get rid of their label. And this is these are adipose-derived stem cells right here. And then here's one with like a blanket over top of it. If you can imagine, this is like the adipose-derived stem cell is underneath. It's got the blanket pulled over itself. It's kind of like my kids on Saturday morning, right? And you can see there's another one right here. There's another one right here. So these stem cells grew into this matrix, and they really enjoyed living there. They started making their own matrix. So you can see that the blanket of matrix that's covering them is what they made on top of the matrix that's underneath. So they only had to make their covering. They grew on top, and then they covered themselves with their own sheet of matrix. So this is the study that we did. It was a 6-day study, an example of a wound healing experiment. Okay, we made these scaffolds. We used human proteins to do it. We used human adipose derived stem cells from donors. We got fat, essentially. Nobody was, nobody said no. It was like, hey, we want your fat. They said, sure, take as much as you want. And then the scaffolds were implanted into a severe combined immunodeficient mouse. Okay? And the reason I'm showing you this guy, there's lots of different things that we do, is because it bridges a couple of different lectures. In the immunology lecture in a couple of weeks, you're going to hear about severe combined immunodeficiency. The reason that we chose this strain of mice is because they don't have a functional immune system, so they have to be in a bubble. Like they live in a little micro-isolator bubble. But we can take a human cell and transplant it into a mouse, and the mouse won't reject it. Because these were human stem cells that came from human fat. Does that make sense? So the importance of this will become more apparent in the subsequent lectures as we talk about the immune system. But we had to pick this particular mouse strain in order to do this experiment because we weren't using mouse fat cells. We wanted to demonstrate that we could do this with human fat stem cells. We compared to a standard of care that you would have at FMC or any other major hospital, and we went 6 days. So we made these wounds in the skin. We surgically implanted the scaffolds into the wound, and these are our day 6 results. So this is all work that we published in Advances in Wound Care, which is kind of a premier journal in the Wound Healing Society. And you can see after 6 days, we've got 60 to 75% wound closure. You can kind of appreciate the green traced margins of the wounds with our control therapy. Antibiotics, an ointment, a covering of a dressing, and this is as good as they did in 6 days. Then we had a tropoelastin or an elastin-based scaffold and then a collagen-based scaffold only, and we added in stem cells, and we virtually had 90 to 100% healing in the same amount of time. So we were able to really accelerate the healing. Now, the big question that the field asked after we published this finding was that because of the stem cells or was it because of the scaffolds? And so now we've actually gone down the pathway of teasing out scaffold versus cellular healing. And the cool thing is if we could get more sophisticated with our scaffolds, we don't even have to go through the step of delivering stem cells now. We can just put a mimetic of scaffold, a scaffold that mimics the skin, and the resident cells in the wound margin know what to do. And so we've saved ourselves a huge step and much faster to commercialization, but we don't have to go through this expensive case of harvesting stem cells. But this is where we started. This was back 7 years ago. We were playing with stem cells thinking we had to use stem cells. Now what we know today is if we get smarter and more sophisticated with our scaffolds, your resident stem cells in your body actually already know what to do. They just have to get the right signals. And part of the most important signal is the scaffold. So we've been able to eliminate this in more recent research, but this is kind of the historic study that kind of started this whole thing. So here's our graphical representation of wound healing. You can see in the 2 scaffold groups in blue, statistically significant differences, faster wound healing in 6 days compared to FMC standard of care. We looked at the thickness of the epithelium, the new tissue that grew, much thicker tissue that's growing with the scaffold that's being delivered. Again, it makes sense. If you have the matrix already there, you're not telling the cells to do as much work because you're already giving them the scaffolding that they like to live in. Okay, so we got 3 major phases of wound healing that we've talked about. We've got this coagulation phase, and we've got this migration phase, and then we've got the remodeling phase. And as we walk through these different phases, the coagulation also turned the inflammatory phase that we've seen in the bar graphs. This is really the trigger point that stimulates the healing when the epidermis is compromised or breached and you get vascular damage. And so this is a cartoon image of what this looks like in 3 dimensions. You can kind of appreciate that there's bacterial cells that you get in. You've got this open wound. You get a fibrin clot to kind of patch it up a little bit. You get cellular infiltration for sure. And over time, we get wound closure that takes place, right? The migration phase is when the cells move in, they proliferate as they're trying to fill in that gap. And then, of course, in this remodeling phase, we've got new collagen that fills that wound, and that wound bed used to be very large, and now the new collagen fills that wound bed. And in that remodeling phase is where you get wound contraction. And we determine whether or not you're going to end up with scarring or you're going to end up with complete restoration of function or resolution. Okay, so I have some clinical photographs that can get a little bit, they may not look so bad on your printout, but when they're like on the big screen, it looks a little bit more aggressive, okay? So in the space, we try to approximate wounds as best we can in the clinic, okay? So this will probably close just fine. As quickly or as soon as possible, ASAP, we're going to try to approximate these wound margins, okay, bring it together. We may pack that bed as we bring it together with a matrix or a replacement tissue to try to minimize wound healing, but there's also a situation where you can't approximate it. There's just no way you can approximate this. And this is a burn model, right? This is a clinical burn versus a clinical wound, right? And at the break, someone asking this question, which is a great question, when your classmates ask, okay, how come in the same patient, right? How come? That's a great scientific question. How come? Right, spell that for me, would you? Why, in the same patient, will a wound heal very differently than a burn? Well, they're completely different injuries, okay? So before, we saw the wound very aggressive, but for all intents and purposes, all that tissue is still there. You just have to bring it back together. Maybe you have to replace a little bit of it. But here, you've lost vast amounts of tissue. So approximation is not always an option, and this is where a lot of our research is trying to fill the gaps, literally the gaps, right? We're really trying to bring in an option when approximation is not a possibility. So right now you've got autologous skin grafting, right? So you can take cadaveric skin and transfer it from one patient to another. You take out the cells so you don't have cellular rejection. You don't have immunology. We've got cadaveric allografts, and we even have xenografts. So they'll use most commonly pig or cow skin. They take the cells out of it, and they just use the matrix. That's another beautiful thing about the matrix is it's not immunogenic. Right? There's no rejection to the matrix. For the most part, these proteins are the same. We have some commercial dermal substitutes. Okay, and this is where a lot of my research has been over the years. So it first started in the late 90s at this company that no longer exists. And we were developing kind of three main products. And the two products over here are for wounds and burns. And this one over here was for the heart, but that's for another time. Okay? The technology was the following. We used a very simple scaffold that we would impregnate with skin cells, grow them in the laboratory incubator, and create a regenerated skin. But we didn't know anything about the scaffold. We were focused really on the cells. Again, this was back in the late 90s. Okay? This is what that tissue looked like. You can see the fiber scaffolds. You can see the fibroblasts, the skin cells that are growing and stretching and grabbing on with integrin attachments to the different scaffold substrates. That was a synthetic scaffold. It was Vicryl. Okay? Very, very similar to that hernia mesh that we talked about. You guys remember the hernia mesh that we talked about? So not the most bio-friendly, but it was very popular. It was like everybody was doing it, right? Just like you needed a biomaterial, you just grabbed Vicryl because everybody used it. Vicryl is the same as, it's very similar to the suture that's used, a certain type of surgical suture. Okay? So this was essentially our replacement skin. And again, these are a little rough, but they're the bottom of the foot. Okay, and let's see if there's, yeah, so you can see this is in October of 95, all the way to like just after Christmas of 1995. And this was at UCLA, so we were enrolling diabetic foot ulcer patients, and the inclusion criteria in order to be on this study was you actually had to have an open wound for a minimum of 6 months. Okay? You could have been seeking treatment during that period of time, but it had to have been non-closed or open in that 6-month period of time. So these were patients, bottom of their heel, as you can see this is the heel, and you can see 6 months, nothing was working, and in subsequent applications of the dermagraft every few weeks, after 10 weeks, completely epithelialized. Okay? It's pretty amazing results back then. These are laser Doppler studies, so they image the skin and tell you information about blood perfusion. So for example, like 1, 3, and 5 weeks, so you can see that in this middle part of the wound that's circled in red, right here, you've got cool colors, so not much blood perfusion. The brighter colors like the reds and the yellows, as you start moving into 3 weeks and then 5 weeks, you're starting to see an increase in blood flow into the wound bed. And that's what gave us this confidence that this was going to be a very angiogenic or a blood promoting technology. And so this is benchtop work on VEGF levels. This is an extremely potent growth factor for stimulating new blood vessel development. So you can see that it ramps up in a 2-day period of time. This is that mesh with no cells. This is the mesh that had the cells on it. You can see all the new blood vessels in this CAM assay. This is on the benchtop versus when you don't have the cells releasing the growth factor molecules, you don't get nearly as many blood vessels growing. So a very angiogenic technology that really promoted this wound closure. Okay, the last couple of slides are pretty rough, okay? So if you've got to look away, I totally get it. Okay, so this was a patient that came to us. This was a chainsaw accident. Okay, so the slip of a chainsaw and hit him across the nose, all the way from the top to the bottom of the face. We reached for this replacement skin, this vicryl with fibroblasts. It's called Dermagraft. Derm for skin, like skin graft, Dermagraft. Not pig, not cow, not from a cadaver. We grew it in the laboratory. This is the first generation technology, and so we had it on the market. We treated this patient. This was a case study that was in Germany, okay? This was in Germany. So our UCLA site was where our clinical studies were happening in the United States, but overseas in Germany, the technology was available sooner. And that's very common. A lot of times Europe will get clinical practice approved or clinical medicine approved before we do here in the States. So Dr. Hans Goff in Germany actually did this study. This is what his face looked like after surgery. Actually looks pretty good. I think Dr. Gath did a great job. Applied the dermagraft in the wound bed. So the stuff that's on the top is not the dermagraft. That's actually the steri-strip just to cover the sutures. And the dermagraft was applied in the wound margins underneath, and then it was closed. And this is 1 year follow-up. Okay, this is 1 year follow-up. Okay, so I want to ask a couple questions. Okay, and what's awesome is when people walk by in the back and they look in, they're like, "Why are they looking at that guy's nose and the weird mustache?" Right? But what is it that I love about the mustache picture? Hair grew back. Okay? What does that tell you? There was definitely some restoration of function, right? Okay. All right, you missed the whole punchline, dude. So I got to go back. Okay. So this is for you. This is for you. This was the chainsaw accident. Dermagraft was applied, right? Fibroblasts on the vicryl. This is post-surgically, and this is one year later. And now we're just kind of observing the outcomes. Is it resolution or is it healing? What do you guys think? Okay. How many of you think resolution? How many of you think it's healing? One brave soul that says it's healing. Why so do you think that it's healing and not resolution?
It's not 100%.
Oh, look at this, perfectionist. It's not 100%. I would agree. Where, do you want the laser pointer, or can you tell us? I agree with you. Where is it not 100%?
His nose.
His nose, okay? Right across the bridge of the nose, I would agree.
His nostrils.
Right down here. He definitely was having issues on the right side of the nostril. You can see it's a little runny. So that was one of the side effects is, you know, you can imagine from the damaged. There were a lot of mucosal glands that were traumatized, and I think they were remaining overactive even a year out. Okay, so you can definitely still see some evidence of fibrotic scarring. So, and then obviously at the lip, you can see right through here at the lip. I mean, I would take this outcome if that happened to me. I would be pretty happy. Okay, but I completely agree. Now you can also understand on the spectrum of resolution and repair, it's typically never 100% of either. It's going to be some blend of the two. You guys with me? And in some cases, it might be more resolution with function returning. If you're growing hair back, now you have hair follicles in that skin that are functional accessory structures. That means that you've got some restoration of function, for sure. Okay? But the evidence of limited, I would call it limited scarring, is evidence that it's not 100% resolution. There is some fibrotic scarring that took place. Yes?
Yeah, the little bit matrix we use to grow the cells, will that be eventually degraded by our macrophages or?
Cells, the donor cells. So the question is, in this technology, these were human fibroblasts. Okay? And I didn't say this. You guys are going to think this is maybe interesting. Where do you think we got the human fibroblasts from? Cadavers? No. It's a good guess. Huh? From skin. What kind of skin? You guys can't say if you know in my lab. Not testicle skin, but close. Very close. That was a very good guess. You're a little low. Foreskin. Circumcised foreskin that was thrown away. Very young skin, okay? It's bio-discard. Scientists are weird, man. Okay? We'll try just put that in, okay? So these were foreskin fibroblasts, okay? And the field is, this is before stem cells were being transplanted. Then I started playing with fat, okay? And the list goes on of the types of things that we played with in the laboratory, okay? But for the record, it's not just testicles. Okay, it was foreskin, yeah.
So did you just take the fibroblasts, or did you actually take?
We just took the fibroblasts. We would take the foreskin and we would liberate the fibroblasts out, and then we would just culture the fibroblasts. Yeah. And so on Friday, I've moved away from foreskin and testicles and all that. Now we actually liberate cells out of placental tissue. Okay, out of the amnion layer of the placenta. We get mesenchymal stem cells, and we get the epithelial cells. And I'll talk about that on Friday. Yep.
Is there a way that people can donate placentas instead of like just discarding them?
Yeah. So this is a very new. It's more prevalent on the East Coast. There's actually not a placental donor network on the West Coast. I'm waiting for one of you guys to start that business. No, I'm serious. Like, it's all very East Coast. There's plenty of, and so for the record, we commercially, I'll talk about this a little bit on Friday night, but these placentas that are used are discarded, but they're really only C-section placentas. Why do you think that's the case? C-section placentas rather than a vaginal delivery.
Bacteria?
Bacteria, that's exactly right. So they need to be sterile because we're creating a medical technology that we're going to deliver to another patient, and we have to screen for sterility along the way anyways. We don't want to start with something that has a high opportunity of being contaminated with bacteria. Okay, but even still, there's so many elective C-sections that are scheduled that are sterile, and those placentas get discarded. And right now, there's 2 tissue banks. Certified tissue banks that we harvest we receive our placentas from, but there's nothing on the West Coast, which is kind of weird. All right, I'm going to find the Nova PBS Facebook lecture, and I will put it on BB Learn for you guys. Given this, I want you to see what else is going on out there, and her name is Doris Taylor. She's a close friend, a close colleague, and she's doing some really cool stuff.
Oh, it's extra.
And I think you guys will appreciate it. All right, have a great week.